Hello everyone, my name is Valeria.
I'm Matt. And I'm Jordan.
And today we'll be talking about how to turn doctors into leaders.
So we're going to begin our presentation with a brief anecdote that Matt's going to provide about why this topic is so important to us.
Thank you, Jordan. One of the most difficult situations to face in medicine is the death of a patient. This issue is often emotional for the patient, their family, and often the caregivers involved. It's also complicated by legal issues, including the patient's own advanced wishes for themselves, the desires of the patient's family, and the goals of the physicians caring for the patient. One particular situation comes to mind where a 97-year-old woman who had recently had surgery, her heart stopped, and she was taken back to the surgical recovery room, which was the only intensive care unit bed available in the hospital because the hospital was full. The physicians put her on life support, did all they could for her, but she was in what is called multi-organ system failure, and so there was really nothing medical left to be done for her. Her family was brought in. One of her daughters flew all the way from California to see her, and after spending time with her, they decided that the best thing that was to be done for her was to have her taken off life support so that she could die peacefully. However, this simple request was difficult to accommodate because of the lack of leadership amongst the physicians caring for this woman. There were multiple physicians with different directives for her at this time. The lack of communication and the failure to agree between these physicians prevented this woman from being transferred out of the surgical recovery room and into hospice care. If there had been a cohesive team with a responsible leader, she could have been sent out of this busy area and brought to a quiet place where she could spend time with her family in her last moments. Today, we're going to talk to you about leadership in medicine. We wanted to suggest a new strategy where patient care teams will be established that will collaborate across multiple specialties. These teams will have clear defined leaders that are in charge of patient care and can establish an efficient way to deliver the best outcomes possible. We hope to avoid situations like the one we just previously discussed. And now, we're going to have Valeria talk to you about patients and their expectations of physicians.
Thank you, Matt. So as patients, we have certain fantasies about the organizations and doctors that are taking care of us. And when I say fantasies, I mean fantasies in the psychiatric sense. What are our hopes and expectations of the medical specialists in charge of taking care of us? A doctor's job is to sustain the fantasies of their patients. If patients feel like they are sustaining them, then it feels like they love us, and we will keep going back to them even if it costs us more. People know that they aren't taken care of by just one person anymore. It's too complicated for that. It isn't like in old movies or in old TV shows like Little House on the Prairie, where there was one doctor in the whole town, and he would pop into your house and check up on you and do his rounds and deliver everyone's baby. Patients have fantasies that doctors are talking to each other, that they believe that if they tell their primary care doctor that they are allergic to some drug, that they will tell their other doctors and that they won't give that drug to them. We as patients have fantasies that doctors care that we are in pain on a Friday night, that if we call them that they'll be responsive, that if we have to be seen faster than in 2 to 3 months, that someone will figure it out and get us in time. Our expectations of doctors are probably lower than they actually should be. If doctors can understand what our fantasies, what our expectations of them are, then we can create systems that sustain such fantasies, and that's a good business strategy. Now Jordan's going to talk about why the current system is not well suited for sustaining patients' fantasies.
So the real problem with the current system is that patients and their physicians really aren't on the same page. If we look at whether patients actually know who's in charge of their overall care, this was an issue in our opening case where nobody really knew what the patient wanted. So in this situation, we actually find that only 18% of patients actually know who's in charge of overseeing their care and who's coordinating the care along the multiple specialties which a lot of patients have to be treated by. In contrast, 67% of physicians thought that patients knew who was coordinating their care. This shows that while physicians think that they're communicating well with patients, the patients obviously aren't getting the message. So there's something wrong with the leadership here. This communications barrier goes even deeper. When you go to a physician's office, obviously your main goal is to find out what your diagnosis is and find out how you can get better. But when patients leave the physician's office, only 57% of the patients in our survey actually knew what their diagnosis is. In contrast, 77% of the physicians actually said that they told the patient what their diagnosis is. So the problem here is that physicians think that they're telling their patients what's wrong with them, but the patients, again, are not getting the message. So, what's the problem? This is the result of a failure in leadership. Physicians have been trained since the beginning of the whole specialty that they're supposed to be independent healers. They work alone. They work through other people, maybe they work through nurses by giving orders, but in the end, they're ultimately responsible for the patient's care. What this has led to is a culture in which physicians just do not like working with other people. Each physician has a specialty, they like to work within the specialty. They're not too keen to talk to physicians in different specialties. And as a result, the outcomes that these patients are achieving are suboptimal. If physicians were just willing to get together and work as a team to meet patients' needs, the results could be so much better. So before we move into our final solution for this problem, we're going to talk about how the current system breaks down along the 5 dysfunctions of a team model. So the foundation of this model is an absence of trust. So because physicians are used to functioning so autonomously and without other physicians' help, they tend to not necessarily trust the opinions of other specialties. Because their expertise are so refined, they feel like people from other specialties just don't fully understand the needs of their patients, and thus they don't fully trust these physicians to participate in the care process. Because these physicians don't trust each other, there's also a fear of conflict that arises. Basically, because the physicians aren't used to working together, they're reluctant to call each other out. So even if they see another physician's doing something that could interfere with how that physician thinks the patient should be cared for, they're going to be reluctant to actually tell that physician, which causes a breakdown in communication that hurts not only that patient, but all the patients that those 2 physicians see at the same time. So the third level of this model is the idea of lack of commitment. So because physicians are so hyper-specialized, they tend to develop goals that are very specific to their specialty. So a heart doctor might have a goal for the patient's heart health, and the kidney doctor might have a goal for the patient's kidney health, but they're not necessarily committing to the overall goal of maximizing that patient's health in the long run. So what this leads to ultimately is an avoidance of accountability. So if something goes wrong with the patients because the physicians haven't agreed to an overall goal for that patient's care, they'll try and pass off the blame to a different physician from a different specialty. A lot of this ends up coming from the legal system, which penalizes doctors who deviate from best practices of care and encourages them to not take responsibility for their mistakes. And what this ultimately leads to is, at the top of the pyramid, an inattention to results. So the real goal from medical care should be to have the patients lead a long, happy, healthy life. But when physicians haven't coalesced around the ultimate goal of making patients healthy as a whole and meeting their expectations for care, and they focus on hyper-specialized outcomes, then the patients aren't treated as well as they could in the outcome, and ultimately they're not as healthy. So now that we've established that there's a clear deficiency of leadership in medicine and that the current leadership style is not appropriate, I'm going to bring in Matt, and he's going to give a brief introduction into how we think this problem can be solved and what the future is of medical leadership.
So, as Jordan previously discussed, the issue with the current leadership in medicine is its transactional nature. Physicians delegate only to their subordinates and don't involve a give and take where they incorporate their subordinates' ideas. We're planning on fixing this by introducing a transformational leadership strategy where charismatic leaders can inspire people to follow them and give individualized consideration to their followers. One of the most important components of our strategy is patient care coordinators, who are nurses that work in the office of primary care physicians. These nurses work on an individual level with complex patients. They talk to them and discover what the patient's goals and desires are for their health care. They then communicate this information to the various physicians who are working with the patient to ensure that a cohesive and smooth delivery of care is given to the patient. The last part of our transformational leadership strategy is inspiration.
So when we're talking about implementing inspiration into our new strategy, we think that this is extremely critical because in order to have this new vision be implemented effectively, we have to actually get physicians to believe in our new vision. So one way that we can definitely do this is by just introducing the physicians to the data. Physicians are very used to looking at studies and implementing that study in how they actually treat their patients. So if we show them the data which shows that, first of all, patients are healthier in systems like this where there's care coordinators, and second of all, patient satisfaction is actually higher. So if we can show them that patients are healthier and patients are happier under this new system, they'll be more likely to accept it and to actually work closely with the care coordinators and coordinate with physicians in different specialties. Another element to our inspiration strategy is getting physicians to actually see each other on a daily basis. That way they're used to working with each other. So if you position physicians who might have worked in different parts of the hospital before and you put them together, they're more likely to develop relationships with each other, and these relationships will inspire them to work together so that they have more cooperation. So ultimately, the goal of our new leadership strategy in medicine is to go from viewing physicians as solo lone healers who don't cooperate with other people to getting them to work as part of a team under a care coordinator that actually responds to patient needs and maximizes patient outcomes in the long run. I hope you enjoyed our presentation today, and thank you for listening.